Hi, thank you for having me. Today, our speaker is Mike Tallhamer. He is the director of radiation physics out in Advent Health, Colorado, and he's also the residency program director there. Um, and Welcome.
All right. Someone's going to have to make me the presenter. There we go. All right. Well, good afternoon, everyone, or good morning, depending on where you're at. My name is Mike Tallhamer. As Adi said, I'm one of the medical physicists here out in our what we call the Rocky Mountain region of Advent Health. I'm the chief physicist over the region, and today we're going to be talking about expanding on non-coplanar capabilities for stereotactic radiosurgery and how that is kind of facilitated using surface guidance approaches. Before we get into kind of the meat of the talk, these are our disclosures as it relates to Advent Health. Advent Health has a couple institutions that have PSAs as well as COE agreements with Vision RT, where we provide site visits, we provide consultations and product reviews, as well as training for staff and for customers. They come out to our institutions to see kind of how we use different technologies and how we implement them in our workflows. As far as the Rocky Mountain region is concerned, we use SGRT as our standard of care. Surface guided radiation therapy was introduced in our system back in 2013 in Advent Health, and I had introduced it in my previous position back in 2008. So this is I'm somewhat long in the tooth when it comes to surface guided radiation therapy at this point in my career. But it is our standard of care in the Rocky Mountain region. We treat 100% of our patients completely tattooless for all indications, everything from heterotropic bone ossification, electrons and osteoarthritis and benign conditions, all the way up to essential tremor, stereotactic radiosurgery for METs, for benign disease, for trigeminal neuralgia, things like that, massless head and necks, and things down as basic as breath hold breast and chest walls. So anything that we treat is touched by SGRT in one way or another. We treat all of our patients throughout our radiation oncology workflow with SGRT, from simulation, planning. We use facial recognition for our patient identification. We use SGRT as a basic patient setup because we have no marks, as well as for active motion management, whether that be respiratory or just compliance motion. And then we use it obviously for treatment delivery and dose visualization, which we'll just touch on just a little bit as we go through this. The learning objectives for this talk is essentially to describe the role of 3D surface reconstruction techniques in expanding the solution space for stereotactic treatment planning and what kind of benefits that brings to that process. We're going to compare it to some of the other commercial approaches from the systems that are currently available out in the market that where it addresses safety considerations associated with non-coplanar deliveries specifically. Explain how surface-based exploration methods improve plan flexibility and workflow efficiency, and then identify opportunities to apply automation to these processes so that we can document these more complex types of treatments for our physicians to review. From a basic understanding of 3D surface reconstruction, for those of you who are not familiar with it, there's a number of different ways to do 3D surface reconstruction. There's two, both active stereovision and structured light, that kind of make their way into radiation oncology. Time of flight and passive stereovision are two other ways of doing it, but they have some limitations that can be addressed, but they're somewhat computationally expensive to address. And so for the accuracy that we need in radiation oncology, we tend to see stereovision systems that are active stereovisions or structured light. And the benefit of this methodology is that it's non-ionizing radiation. This allows us to do continuous real-time motion management and real-time applications for our patients without exposing them to additional ionizing radiation. So it has an attractive methodology for positioning our patients and for getting additional information for our planning processes. The way it works is essentially with active stereovision, we have essentially a pseudo-random dot pattern projected into space. As we put a three-dimensional object underneath that, it distorts that pattern, and two cameras can find a common feature within that structure. Those common features are triangulated into vertices. Those vertices are then reconstructed using either like a ball pivot method or a Poisson reconstruction or some other type of reconstruction method to create a 3D surface. And those 3D surfaces are obviously subject to the visibility of the surface by the camera. So sometimes you'll see some holes, sometimes you'll see some missing information, and that's based on the obstruction of that pattern during surface reconstruction. The other one is the structured light pattern, where we're projecting a structured light pattern into space, and as we bend a 3D object underneath that pattern, it distorts the pattern, and those distortions become our features, which then get triangulated and create that same 3D surface. And so there's a number of different commercial vendors. There's about 6 commercial vendors now in the market doing this, 5 of which I believe are currently available in the United States. And they use one of these methods to create these 3D surfaces. We're used to seeing this traditionally in SGRT. When people think of SGRT, we think of SGRT at the treatment machine. And so you see things like this on the left-hand side, where we're setting up a patient's surface, where we're focusing on our ROI, which is the green area you see here, and we're trying to get that within 6 degrees of freedom. About 2020, 2021, postural video became kind of essential. We felt within our clinics, we do not have a clinic that does not have this postural video feature. This is a high-pass filter of the 3D surface, allowing us to project it onto the video of the patient so we can correct this patient's posture far away from isocenter. So, and this is the same patient, so you can see the ROI is in the right position, but in this case, her elbow is too low and her chin is turned too far. The reason why we want to do this is because as we do IGRT, we want to make sure that we're not over doing the imaging or needing repeat imaging because the overall posture of the patient is not in the right position. We also deal with changes of position or changes of body anatomy. So we can see swelling, we can see things like weight loss, and we think of GYN cases, they have parotic nodes, they tend to lose a substantial amount of weight during treatment, or head and neck patients tend to lose weight. This can identify areas of surface distortion or deformation. In this deformation screen, we can kind of address these things, but these are all happening at the treatment machine. After it was introduced at the treatment machines, SGRT kind of moved into our CT simulators, and with our CT simulators, we're now using them as ways of doing contactless 4D CT simulations. So in this case, you can see we're just using a surface and a small ROI on the abdomen of the patient. The system can detect abnormal breathing and let the user know that there was abnormal breathing. It can also learn the pattern. So as it transitions from something that's learned to, or unlearned to learn, you can coach that patient into a more regular pattern. And when you see a regular pattern, the beam can be triggered for CT simulation. This same process can be used for deep inspiration breath hold coaching at the time of CT sim to make all of these things much smoother at the machine. So expanding that SGRT technology back to the CT simulator. There's new applications of surface guidance as well. Just a brief overview of this. This is Cherenkov imaging. This allows us to see the Cherenkov emission from our patients that we get for free when we irradiate our patients. And what that allows us to do is to validate basically the beam on the patient in real time. And so what we're imaging in real time is the Cherenkov emission, this case for a prone breast patient whose first 2 fractions look like this, which was what we would expect from the treatment plan. And then on her 3rd fraction, she dislodged this pad. You can see the pad is emitting some Cherenkov imaging, as well as some Cherenkov due to the exit dose through her arm. If we were to leave this unaddressed, she would receive about 40 gray if this was to happen every fraction through her upper arm, and you can imagine getting some arrhythmia and some skin reaction here. And so we can make these changes in real time. We can stop the beam. We can address whatever's causing her to pull her arms underneath her. In this case, it was back pain. We can address that, reset her up, and actually avoid these types of treatment mistakes that we can't actually see outside of the surface guided approach. But you can say, well, how do I know in this case that that was an error if I didn't have, say, this previous image to compare to? How do I know this isn't what was intended from the plan? Well, we have these situations where we have 2 prone breast patients. This is out of our Celebration facility, where we have obviously 2 different posterior coverages on this patient. And so we want to know, is this planned exposure or is this unplanned exposure? Is this underexposure? Is this overexposure? We need to know some sort of a priori information. And what surface guidance allows us to do is now, in the future, project the planned information directly onto the patient during setup. So as we're setting up these patients, we can see both the postural video outline to align this patient, get the breast in the right position, but we can also see this white outline, which is the projection that would be expected from the plan. This orange is the live projection on the live surface, and so we can see that the orange is inside the white line, and so we would expect if we had Cherenkov imaging, we should see this, and in fact, we do. We can see that what was intended from the treatment plan and approved by our physician is actually what's being delivered on our patients. And so surface guidance is moving more and more across the treatment workflow, and we see applications in sim, treatment, and dose. But what we'd really like to do is increase our efficiencies, increase some of our planning complexity and abilities by moving this information back into the planning phase. And that's what we've done with our institutions here in the Rocky Mountain region, and also in Florida, where a D station is. We're moving this information back into our planning phase and allow us to use this surface information to facilitate a lot of interesting types of planning, but also take planning that we're really familiar with in certain instances like intracranial SRS and move that to other body sites with more ease and less learning curve for our dosimetry teams. And why would we want to do that? Well, there's plenty of publications out there right now looking at non-coplanar planning and non-coplanar delivery techniques for things like lung cancer and breast cancer and head and neck cancer. I've seen cervical papers and prostate papers and all of these things coming out showing that non-coplanar planning may have particular benefits in certain circumstances. And we don't want to overstate the benefits, but we also don't want to ignore a technique that could potentially benefit our patients, because as they live longer with these diseases, we tend to come back and retreat these patients. And so we want to make sure that we're being as efficient with our deliveries as we can as we go through treatment. Those were standard treatments. We're also seeing this in SBRT. This is a recent paper from 2025 looking at lung cancer that replanned 288 lung SBRT cases that were planned coplanar, and then were replanned with a non-coplanar arrangement. And they saw non-coplanar plans were more conformal across all isodose levels and had no negative trade-offs on the OAR sparing. So heart, lungs, bronchus, chest wall, all of the things that we're concerned about, spine, during these lung SBRT treatments. So there's some encouraging data that's out there showing that these non-coplanar arrangements can be beneficial, and especially, like I said, as patients are living longer. There was another paper, this is a paper from 2024, showing that not only could it be beneficial from a beam arrangement, but also we may be able to identify these patients based on tumor size. And so when you're talking about an organ like liver that is a parallel structure, you want to make sure that you're limiting the amount of healthy tissue receiving certain isodose levels. And so in this study, they looked at lung tumors and found that larger tumors benefited more so from non-coplanar arc arrangements than smaller ones. And this is largely because a lot of these patients who have larger tumors, you're also treating a number of tumors in the same session. So maybe instead of just one small liver tumor, you might be treating 2 or 3, even 4 large liver lesions, and you're trying to reduce the integral dose across that parallel structure. So what I've done here is I've just pulled some studies from after post 2020, looking at different body sites. So GBM for brain, so larger targets, brain metastases and SRS, so stereotactic radiosurgery, whole brain where we're looking at sparing like the hippocampal structure, head and neck of various different indications, cervical cancer, liver SBRT, and lung SBRT, so the site plus a technique. So this is being stereotactic radiosurgery of the body, and then prostate being intact standard regimen prostate. And all of these papers showed an advantage to non-coplanar planning in some way or another. And their metrics were their metrics. And so the check marks here are out of 4. This is the general advantage that non-coplanar planning showed within these studies. These are the key studies. I'll show you the references here in one moment. These are just click-throughs in case they provide this talk later on. And then the disadvantage were mostly around the longer planning process, the delivery being more complex because now you worry about collisions, planning complexity again, planning burden, QA, again, related back to the collision risk and at delivery time, workflow complexity, largely around planning, delivery time, again, with the concern of additional dry runs, those types of things that need to happen, setup complexity, again, related to the collision risk. So a lot of the disadvantages were listed in these papers, and they were very upfront about the challenges that are associated with non-coplanar planning. And the recommendations, though, however, all kind of focused around you should use non-coplanar planning in a lot of cases. I believe the cervical case, they recommended coplanar because there was minimal benefit along with prostate cancer. But that coplanar in special cases where you are having difficulty meeting some of the dose constraints was still recommended. So this is a good overall idea to be as honest as we can about the benefits of non-coplanar, but maybe not in every single case. And so we want to use this in an effective way, and we want to make it easier for our dosimetrists and our staff to apply this technique. These are the studies that go along with them in the order that you saw on that table, so you'll have that as well. But how we would do this, we have to think about the workflow that goes into it. So currently, when we're doing, say, something like an SBRT lung or radiosurgery for the lung, we have a CT surface that encompasses what we need for dose calculation, and that's what we focus on from a radiation oncology standpoint. But if we take an optical surface of this patient, we can see that the amount of anatomy that's around is much more than what we CT, and we all know that that's fairly common sense. We can fuse this information in DICOM space, and we can see that the CT is a small subset of the overall information. The same is true for stereotactic radiosurgery in the intracranial cases, where we have a very small CT. We may have an inpatient or a patient that has a lot of other things going on anatomically, because these are usually sicker patients. And we can see that once we fuse this, we have all of the information. And the information that we're seeing in the optical surface is the places where we're concerned for noncoplanar planning. We really do not want to collide with any of these regions, but they're not included in our CT scan, typically because we don't need them for dose calculation. And so we want to leverage this optical approach. And what we do is how we do that is we have essentially installed 2 additional surface-based cameras in our CT suites. Those cameras allow us to capture a full body surface of a patient, and people always ask, how big can you go? We've captured up to about a 6'8" individual with their arms above their head, very much in the orientation that you see here. This is not that individual, but this is similar to what you can capture from a very large patient. And what we want to do is we want to calibrate this system. And this system is calibrated just like any other SGRT system, usually with a dot matrix that basically sets an external optical geometry for the coordinate system. That coordinate system allows us to anchor our surface at the origin for the optical system. And then we have some sort of transform that moves that to our DICOM geometry, which is based on the DICOM conformance statement for the CT scanner that we own. So here in Colorado, we have a lot of Philips scanners and some GE scanners. Out where a D is, they have Siemens scanners. And so there is a DICOM conformance statement that will give you the transform from that optical calibration position to the DICOM coordinate system that we use for planning and radiation oncology that we're all familiar with. So what that allows us to do is to do interesting things like this, where we can take a treatment plan, we can take a blue patient surface and merge that with a gray machine surface. So now we're using surface guidance not only for the patient anatomy, but also for the machine anatomy. And we can look and identify indexing issues. We can identify if we want to use triggered imaging. We can see if there's going to be clearance here. And then we can take it a step further and go into the treatment geometry and do what we call clearance mapping. Once we load the geometries together, we can set the indexing as we are here to what we would use during treatment. And then we can generate a clearance map, which is what you see in the center. And this allows us to basically move through the choreography of this SRS treatment to make sure that we have collisions or no collisions, and that we have optimized the delivery for speed. And so we can also go to nearest approach, like the dosimetrist is right now, and see what are we going to come close to. In this case, the shoulders and the elbows are pretty wide. He's a pretty broad individual in this case. And so we're just making sure our closest approach is, so if we need to add anything to the setup notes of maybe lowering the hands on the abdomen to kind of narrow his frame to make collisions less of an issue. And so we can use this technique in intracranial SRS. And we all know that intracranial SRS is high precision, high dose. It's an ablative treatment. At least at our institutions, we're treating somewhere in 4 to 6 arcs typically. While collision risks are significantly higher because we're going to these non-coplanar geometries, technologies like Variance HyperArc has been introduced into the market many years ago to kind of artificially reduce that risk of collision based on the fact that they can limit the solution space to a defined set of beam geometries and a imposed immobilization system. So if you work within their framework, they have a model that allows you to basically calculate where the patient's going to be based on the CT geometry, and it's basically for intracranial cases. And so if you work within their framework, the risk of collision is very low. You can also apply some automation to the planning, which is very nice, but you are artificially reducing your solution space to a known geometry for the trade-off of not having these collisions. The thing that we like about surface-based planning is it enables the planner to explore the full solution space for intracranial SRS with confidence, knowing that they're not going to have to emergency replan this patient because a dry run identifies a collision that was unknown or not part of the calculation model. And we can do this in a multi-target, single isocenter type of thing where we can now more efficiently deliver these fractions to these patients. And you could say, well, I can look at the single isocenter multi-target case where I'm treating 3 lesions with a single isocenter. Everything's ipsilateral in this case, so not a hyperarc patient. This gives integral dose to a favorable region of the brain rather than spreading it out throughout the cranium. And we can say, well, we can visualize this and say that we probably will not have a collision with this based on just knowing our system and knowing our geometry. But if you could take this exact same patient who returned with 19 METs and we needed to treat with 4 isocenters and 20, I think 19 fields or 21 fields, if you can look at this geometry and tell me that isocenter 2 field 8 has a collision and is going to require a re-optimization of this plan, then you are much better at spatial relationship than I am. And so what I need to, as a mere mortal, use is something like surface guided planning. And what we can do is leverage some of the API features that the vendor has provided to us. We write ESAPI scripts to allow us to basically do this from within the Eclipse platform. You can do this within the RayStation platform as well, with the scripting and access the API. And you can check isocenter 1, fields 1 through 5, and see that there's no collision. But then you can check isocenter 2 and see that field 8 is going to cause a collision. And since you're synchronously optimizing this, you want to make these changes before you optimize all these plans as one overall delivery. And so we can make these changes inside the planning system. We can explore the solution space and figure out what gantry couch combinations will work and what arcs will work. And we can enter those values and continue optimizing. And this saves us about 30 to 45 minutes when doing these more complicated plans, because we can easily set these beam geometries very quickly, and we don't have to rely on like known geometries or pre-canned geometries. And so you could say, well, I like HyperArc. Well, here's a HyperArc style case. This is the HyperArc beam arrangement. In this case, you can see that we have shortened a couple of the arcs in certain areas to avoid previously treated areas. But this would be considered somewhat of a chip shot at our institution. It's a single isocenter, single small MET, very non-eloquent portion of the brain, pretty easy to hit. But this patient showed up complaining of neck pain because of an injury and wanted his head elevated a little bit to avoid neck pain. And so we accommodated. And when we put this through our system, surprising to us, we found this. So on one side, we have a false positive. In this case, because it is a surface technology, we do see that we captured a sheet. And so we can see that visually in the representation. We're not relying solely on the collision map, but we can go to the point in the collision map where we see a collision and see, oh, that's a sheet. So that actually won't be an issue. So that was a false positive. But in this case, we had a true positive collision with the couch indexed at the right position. And the reason for that is because of the anterior position of the lesion, the size of the patient, caused the isocenter to be very high, which makes this couch very low. And then we had a collision not on the non-coplanar beams, but on the couch at 0, which is a very atypical circumstance. But the system allows us to evaluate these things very quickly and avoid having to replan something like this over an afternoon so the patient can come back. Because here in Colorado, we oftentimes get people from Wyoming and Nebraska and Kansas and all over the place. And so we don't want to do this and cause them an extra night stay in a hotel or another set of QAs and planning and all the things that we need from a physics team's perspective. We can avoid this right at the planning process itself. So we looked at a retrospective review of about 30 SRS cases. I imposed some constraints on the review that said you cannot change the optimization parameters and cheat. You cannot add beams, and you cannot kind of drive the optimization harder than what you did with the other one. You had to keep the same optimization parameters. And so with the same optimization parameters, the major changes, just looking at surface-based planning as as minimum intervention as possible, we basically increased arc lengths or increased table spread across the number of arcs that were used. And we could basically improve all of the metrics of these plans, even though we are a very heavy non-coplanar user within Eclipse. So we've been doing this for many years. We have what we would consider very good intracranial SRS plans, but we were able to improve even on the plans that we had because now we weren't using calculation-based models to predict what the couch spread needed to be. We were actually using the surface guided information to better these plans. And so what was nice also, we had 2 cases that we could actually grab that did have collisions when they did dry runs, and we wanted to see if the system could predict that. And obviously the system very easily identified that those 2 cases were going to have collisions. It would have saved us all of the replanning that would have been, well, that was required for those 2 cases, but would have been identified in this study at the time of planning and been avoided at the treatment machine. The advanced API also lets us do interesting things like this, where we can take the surface information, we can extract it from the SGRT system, we can reconstruct it using Poisson reconstruction and isolate that surface, and then renormalize it so that we can then voxelate these surfaces and turn them into synthetic CTs. That means we can edit out things like sheets and all of those kinds of interesting things. So if we want to get really, really close to a patient, which we don't typically want to do, but if we needed to for planning purposes, we can actually edit out some of these features. We can then take those surfaces and stick them directly into our treatment planning system. So in this case, this is a body contour. that was obtained from the optical guidance system, and now we can edit out sheets. We can edit out things that we don't want to see in the collision map. We can actually put in the synthetic CT and use that to expand information that we didn't CT through. So in this case, this gentleman has very broad shoulders. And so we can actually add that CT information into this so that if we want to check with other collision model systems, so this is ClearCheck's ClearCalc has a basically geometric rudimentary collision checking system. We can edit out all the things we don't want and run that through in our treatment planning system very easily and make sure that we've addressed any other concerns that may have popped up during planning. We can then push this onto our surface guided radiation therapy system as an entire CT or as an entire surface. And now we can use postural video to make sure that the patient's shoulders and elbows, even though they weren't CT'd, are within the frame that we used for contouring, which within the frame we used for planning and for clearance mapping. So if his elbows are splayed out too far, we will see that in the surface guidance system and know that he's going to come too close to the gantry, and that we could ask him to move his hands down onto his abdomen farther so we can kind of help narrow his frame to make sure he stays within the envelope that we planned in, and so that we don't run into additional dry run tests that we need to run, shortening that time on the treatment machine. And so we're going to end kind of the conversation with looking at what this means with minimal effort. So you can put a lot of effort into noncoplanar planning. We put a lot of effort into our noncoplanar planning, but I wanted to give a kind of a sense of this doesn't have to be a complex process. This can be something where you make minimal changes for quite a bit of benefit in a lot of different circumstances. And so here is a minimal benefit type of situation where we have a noncoplanar plan that we delivered at our institution at the top. So this is something that we generated this plan in the early days using our collision models and our indexing models that we would, calculate out what we felt our maximum table spread could be. In this case, our model was relatively conservative. And we could see that we went plus 15 degrees, minus 10 degrees. And so we ended up with about a 25-degree table spread. And we were able to meet most of our dose constraints and everything on here. I think the gradient was the only thing that failed in this case. If we put this back into a surface-guided planning workflow and we actually use the surface information that we captured while we were commissioning the system, we found that we can actually extend this from 25 degrees to 38 degrees very safely. This is with a 2-centimeter buffer. So we don't come within even 2 centimeters of our patient during delivery, but we were able to add 13 additional degrees of table spread. And what that means for us is we still meet all of our dose constraints. We haven't changed the optimization parameters. We haven't done anything differently. We have the same coverage with slightly less hotspot. So we've reduced the hotspot, and we've met our gradient index, and our conformity index is slightly better. And that purports with what we see in the literature, saying that, the more noncoplanar your arrangement is, the less overlap of the beams farther out in the patient. So you would expect gradients to get better, conformity indexes to get better. And there was no additional optimization pushing on this. What's nice to note, though, is because we've now opened up that table spread, we can actually drive this optimization even farther. So we could have actually made many of these parameters much nicer because we could have pushed harder on them, because we're not fighting these overlapping fields any longer, because now we've spread out that table. And now we can actually push the optimization harder. In this case, we didn't push it harder, but you could push it harder. And if you had something like a heart dose or something that you were concerned about, or a chest wall dose, you could push even harder on this patient and not at a detriment to the plan quality. You can use this as an example. This is a noncoplanar lung SBRT that was done at one of our Florida institutions before they started doing a lot of noncoplanar. They failed to meet the heart ROI, the RTOG 2cm dose fall-off, which is a gradient index essentially, and then failed to meet the conformity index from our institutional measures. And this was because it was sandwiched between the heart and the chest wall, and they were confining themselves to a coplanar beam arrangement. If you look at going to noncoplanar and keeping the same optimization parameters, just essentially spread the table out and then hit reoptimize, don't change anything, you could easily hit all of the metrics that we were failing. So you could see the conformity index and all of the RTOG gradient index and the heart doses. All of these things were immediately made better with no other effort than just spreading out the table and hitting reoptimize. But some of the other things that we look at that didn't necessarily fail, this V30 for the chest wall is a pretty good indicator of future pain. And we dropped that from 19 cc's, which was below our 30 cc metric, all the way down to 6 cc's without trying anything else. This was without additional pushing on the chest wall. This was just spreading the beams out and using a noncoplanar arrangement. And so there's some benefit with minimal effort. So these arguments that plan complexity has to be very difficult, some of it is just use your same optimization. You don't have to change your optimization strategy. Just kind of spread the beams out for what you can see geometrically works for the patient. Here's a liver SBRT. We talked about the liver SBRT study from 2025 that showed that larger lesions tend to benefit from noncoplanar arrangements. We've been doing our liver SBRTs noncoplanar for probably 15 years at this point. 11 years, 12 years. I shouldn't say 15 years. But we use, again, a calculation model because we're deeper into the abdomen. There's much more concern for collisions with the patient and with the couch now because of the size of some of these patients. So in this case, this is a caudate lesion. We were actually treating 4 lesions of similar size, so fairly large lesions within this liver. And our calculation model showed that we could use plus or minus 10 degrees. So we had a 20-degree table spread. And we got a plan that passed, didn't have any major issues with this lesion. And then when we summed all of them together, we had a passable plan. We had a good SBRT plan, we felt, and it was all non-coplanar. But if we run this back through a surface-guided approach, this is what we could do with surface-guided approach. So this here is I believe a 40, or what is this? This is again, a 38-degree table spread on this caudate lesion. And what you're looking at in these profiles is not coplanar to non-coplanar. The red is a non-coplanar plan, something that we would say is a very good non-coplanar plan. But just by increasing the spread between those two beams and just hitting reoptimize, again, not pushing any harder, not doing anything crazy, we have reduced this low dose spread significantly just by using that additional space that we have available to us because we now know it's there. And so for the single caudate lesion, we reduced the 12.5 gray line by 52.31 cc's. I didn't have the total plan on here. I should have put the total plan statistics on here. I believe this is about a 1200 cc liver. The total 12 gray line reduction was something like 270 cc's. So over a quarter or over 20% of the liver was spared at the 12.5 gray line just by spreading out the beams, not doing anything crazy, not doing anything, ridiculous and getting really, really crazy with the patient, but we just spread the couch out and said, we're going to have the same arc length with same everything, same treatment time, but we've significantly improved the plan quality simply by kicking these couches farther apart. And so here's a non-radiosurgery case. I apologize because it's an RSS meeting, but this I thought was an interesting case. This is a patient who had previous breast treatment, so had left-sided breast treatment, DABH. So we've already had a little bit of dose to her heart, not a lot, and we've also had a lot of dose to her breast. And so one is a coplanar plan arrangement. This is now actively planned with surface planning. This is a large lesion, but this is coplanar, and you can see this 25% line is spreading way out into the breast tissue. And if we use a non-coplanar arrangement, we can significantly reduce the amount of breast tissue that's actually receiving the 25% line while increasing or basically keeping the same coverage in the same hotspot. And so if we look at what that looks like from a planning perspective, the dosimetrist was able to go from what would be 2 arcs in a coplanar arrangement straight down the middle to 2 arcs that were shorter but were kicked off on either side and allowed us to do a 35-degree couch spread and decrease the amount of dose to that or the ipsilateral breast significantly. It also reduced the dose on the heart. You can see here from the DABH, the ipsilateral lung dose V20 went down, the heart dose went down, the overall lung V20 went down, but the coverage on the PTV remains the same. And so, again, with a simple couch spread and reoptimization and critically looking at what the surface guidance is telling us, we can actually make advantageous decisions for these patients and not increase their treatment time, not increase any risk of collision with the patient because we're knowing what that geometry looks like. And if we're uncomfortable with the geometry, we can increase these buffers at any time. So right now we're using a 2-centimeter buffer. We could say we don't want to come any closer than 5 centimeters to this patient. And that's going to obviously decrease the solution space, but it's going to still allow you to visualize what type of plan can be achieved without actually having to take this to treatment and find out that you do have a collision with the patient and having to replan that patient. With any technology implementation in the clinic, you do have to be careful that you don't introduce additional errors. So here's an example of an SRS patient that was captured with the surface guidance system. So we have an optical surface and a DICOM surface, but when we merge these two surfaces, we can see that they do not align. And what happened here was the gentleman we made an open face mask for the SRS. He had to use the restroom. He got up, he came back, and one of our therapists by mistake re-zeroed the couch, which re-zeros the coordinate system for the optical system, but not for the DICOM system. And so, or I should say vice versa, re-zeros it for the DICOM system, but not for the optical system. And so what ends up happening is we have a misalignment, which means we cannot trust the clearance map in this case. And so we're using the API, we're using these things to better decide how are we introducing these errors. Because if we're going to advocate for an efficiency in the workflow to maybe go to fully digital or all digital clearance checks, we need to make sure that we're not introducing a hole in our Swiss cheese model that passes directly through the model. And so in this case, you can see this is a single patient. This is the patient that you saw just recently on the previous slide. And you can see he's both a lung SBRT and an intracranial lesion. And so if you zoom in the commercial software, you can see that the isocenter in this case is way outside of his head. And that's because it's inside the DICOM geometry. It's not inside the optical geometry, and that those two geometries do not align. The issue we have is he also has a lung SBRT, and we do not know in this case, because we can't see this indicator on the patient because it's deep inside of him, if the same mistake happened for the SBRT. So we need some way of addressing that. And so this is where dragons lie. This is where all of the old maps, this is where the sea monsters are. This is where we need to understand a new technology, an exciting technology does not mean a flawless technology. And so we need to introduce quality assurance measures that allow us to visualize these things in ways that prevent us from making these mistakes, looking at that astro safety is no accident kind of forcing functions that prevent us from making workflow mistakes, because we know policies and procedures are very low on the hierarchy of effectiveness. So we can tell people not to make mistakes, but that doesn't mean they're not going to work their way into our system. And so in this case, we have different validation routines. This is, again, our API that we use to kind of pull the system information into a more kind of user-controlled environment. And so this is one of our API applications. And you can see on the left here, this patient was obviously captured in the wrong position. The body is over top of the head. We would not expect that this would be the proper treatment geometry. But if we ask the system to provide a clearance map, we will get a clearance map for this geometry and for this plan. But this is clearly not right. On the left side, we see our SRS patient, same patient as we saw before. And when we pull that information in, we can see that there's a misalignment. In this case, at SIM, we identified our error, recaptured the surface. We could see that it aligns, and we can also recalculate the clearance map for this patient. And you can see it's drastically different. It looks completely different than the other one. We can flip between them. And you want to avoid wanting to treat something over here and moving your patient into an area where there's a collision because you had a false treatment map. And so this software allows us to basically make adjustments. In this case, this was not identified, so this is being corrected at planning. So the dosimetrist is basically refusing the DICOM and the optical surface. And after they get it fused, what they're going to do is essentially recalculate that clearance map. And then now we have a clearance map that we can use for planning. So in this case, there's no collision up here, but there's a big collision down here. You're going to see as he calculates a new collision map or a clearance map, you will see that there's actually a collision in both locations. So had we adjusted this to avoid this collision, but not this one, you would have seen this slight difference would have resulted in a collision that was undetected. And so again, these are things that we have to think of as we go into non-coplanar planning, and we have these incredibly nice tools, that these tools can be used inappropriately, and that we do have to incorporate this into some of our quality assurance. And when we put all of this together in an entire radiation oncology workflow, we get something like this. We have this patient who has 7 arcs, breath hold, bilateral chest wall, superclav, previous treatment, a lot of difficulties that we have here. We can check the clearance maps. And in this case, it's not non-coplanar. This is a coplanar geometry, but it's a very complicated geometry because of all the other things we're throwing at it. And so we evaluate non-coplanar, we evaluate coplanar, we find out which plan gives us the best optimization around the previously treated area. We then need to treat this patient. And in this case, this is a schematic of the treatment. We have to treat one chest wall in superclav. There's a number of interventions for SGRT along the timeline at the top. We have to set them up. We have to center the couch. We have to do a breath hold cone beam CT. We have to place a bolus. We have to take a new reference, and we have to treat the patient. We then have to transition to the other chest wall. That has to be done using SGRT because on the true beams, at least, you cannot transfer cone beam CT shifts from one isocenter to another. And then you have to then treat the other one. So now you have to verify with an image, take a reference, place a bolus, take another reference, and then treat. And so all of this information and all of this has to be executed at a very high degree of complexity at the machine. And this is what we see in our OIS. We see a cone beam CT, we see some treatments, we see a shift, we see a table move, we see another image to verify isocenter, and then we see some treatments. But if my therapist did not execute an SGRT step at every one of these arrows, every one of these green arrows is a breath hold, every one of these reds is a transition from one setup to another, every blue is a reference image, all of these things need to be done correctly. Otherwise, what we're approving is essentially a blind faith that everything executed at the machine matches up. And we have 2 instances in time where IsoCenter looked pretty good. And so what we want to do is document these things. This is, everybody knows the new documentation requirements for the 2026 billing requirements. These treatments are very complex. We're using active motion management. And if you want to build these things, you have a lot of different types of information that you have to document that you're checking on a daily basis before the next treatment. And so we want to investigate what automation looks like. And so what we've done is implemented an automated process where we're used to seeing something like this, say for a chest wall or a breast, where you get some sort of imaging, IGRT, a physician approves it, it has a date and time stamp before the next fraction, and that satisfies all of the current requirements for the 2026 billing, along with the medical necessity documentation that is obviously required for active motion management. So we would like to have a similar workflow that doesn't require our physicians to do a lot of extra work. And so what we've done is added an automation module to our setup where we now have these AlignRT screenshots and AlignRT reports. And what that looks like is this. So in this case, for a standard breast with DABH, the patient is in position, the beam gating is turned on, and everything was ready to go before the beam was treated. And then after the beam is treated, we have a report that shows that for every breath hold, she was in tolerance and that there's no unforeseen issues during treatment. We can move this to the stereotactic radiosurgery realm where we have a stereotactic target. In this case, the volume, the PTV overlaps the brainstem. And we want to hold this patient to 1 millimeter, 1 degree. So we're going to look at where was he before the first beam, 1 millimeter, 1 degree, everything's in tolerance. Again, 1 millimeter, 1 degree at his second couch kick, 1 millimeter, 1 degree at his next couch kick, and so on and so forth until the treatment is done. And so now we are filling in the gaps using surface guidance and automation of not only did we plan this patient, we know that the noncoplanar is working correctly before we get him to the treatment machine, but we can also document that all of these things went according to that treatment plan and that workflow when they were finally delivered at the treatment machine. Again, you can have a total report. If your physician wants to see a total report, you can actually include that as well. But all of this goes into their automated standard IGRT workflow, whether it's Mosaic or ARIA, so that the physician's not trying to find documentations in document sections or go into DNI to find this or going into documents to find that. Everything that pertains to the treatment is in the radiographic timeline, the way it was done at the treatment machine, and they don't have to ask for any additional information. So in summary, 3 reconstruction methods are very powerful. They expand the planner's ability to explore the stereotactic solution space and help visualize noncoplanar clearance. Commercial systems improve the safety and efficiency of surface guidance, collision awareness, and delivery checks. So now you can do these automated delivery checks before the patient's even present because you have that 3D surface. Surface-based exploration improves planning flexibility by making clearance information visible earlier in the workflow at the time of planning, so you're not relying on calculation-based models or guessing or just fear of collision, so you just stick to coplanar arrangements. And this reduces the need for additional dry runs and support more efficient planning development. Automation can standardize the documentation of all of this complex delivery, so you're not relying on your therapist to add additional things to their workflow, like exporting PDFs, putting them in a proper folder, importing them into the right patient, notifying the doctor that there's a document. All of that stuff can be avoided. And then together, all of these tools can help make stereotactic treatments and these non-coplanar beam arrangements more flexible, more efficient, and preserve the precision and accuracy that we need for these types of complex cases. And so with that, I want to be respectful of time. So thank you. I thank the Advent Health Physics team, everybody that goes into doing these things, Adi doing it out there in Florida, and the collaborations that they provide for us to be able to do these types of complex treatments. So with that, I will say thank you, and then I will turn it over to the moderators for questions.
Thank you, Mike. That was a very, very detailed presentation. We have a couple of questions in the in the chat. Let's start with the first one. Do you use fiducial markers for liver SBRT with SGRT?
We do when we can get them. So it's very dependent on your surgical team and their willingness to place gold fiducials. We like the carbon fiber fiducials personally because they throw less artifacts, so it makes it easier on our physicians to contour. We get those whenever we possibly can because we like to have those in there. That is an internal target relative to the surface, and so you do have to be careful of what the correlations are. Some correlate very well, some correlate poorly, but we get them when we can. Our surgical teams tend to shy away from them just because of the bleed risk associated with the placement. So
Do you feel like the shifts, if you're doing a cone beam lining up to fiducials, your SGRT shifts kind of change for better, for worse, or like you said, depending on
it
placement?
depends on the technique used for, like, all of our livers are either done breath hold or under compression. And the compression that we use is non-paddle based. It's a abdominal compression. We're using a mask, so it's more like a girdle. It's much more stable. And so we did a study between compression paddles and those like pump up pneumatic belts and this compression masking technique. If you set up with SGRT and you use the compression mask, your shifts are always pretty much under 5 millimeters or less. It's usually under 3 millimeters or less, which is largely within our PTV margins, which we were happy with. If you're using a paddle or a belt or something that has localized pressure where you're crushing them down to their spine, it's all over the place. We've saw shifts up to 1.5 cm in some cases because the tail of the liver is very mobile depending on how that compression is done. And so it's a combination of SGRT utilization combined with your mobilization, combined with your compression technique. You can get very stable setups or you can get very wildly unstable setups. And so that's why the fiducials are a comfort level for us, because we know our technique is very good when it comes to the compression mask, and we know that the shift should be small. And if we align with SGRT and then do a cone beam, if those shifts are under 3 to 5 millimeters, we know everything's set up correctly.
Yeah.
That is not the case at places that use paddles and belts. And so you could set up with SGRT and then find out you still have a 1 centimeter shift because you smashed the liver completely
Mhm.
to one side of the body. So again, it's not an SGRT and it's not a technique. It's kind of an interplay between the two.
Yeah. Okay. Second question. Um, do you ever use SGRT as a means of post-shift verification of couch corrections for SBRT?
We do watch, so that's if you're familiar with TG302 or the ACROP guidelines, the dynamic localization test is kind of that. And so when we apply shifts with our cone beam CTs, we're watching the SGRT system to make sure that that goes where it is. You can think about the early days of cone beam CT, everyone was like, did the couch get there? And then you do another cone beam to verify that it got to where you said it should go. And I don't know if anybody's ever found where the couch didn't make it there, but it goes there. Secret's out. At least if you have a true beam, I can tell you it really makes it to the position. And so we use it as kind of a sanity check. When we apply the shifts, we want to see that those shifts are recorded by the SGRT system and that something wild didn't happen. If we see something unlike the shifts that we just applied, it's usually the patient moved during that process. And that's usually an indication that we do need to check that positioning before we do SBRT.
Yep. It's a broad question next. Uh, for radiation oncology department preparing to implement SGRT, what key considerations or potential pitfalls should be carefully anticipated?
When implementing SGRT broadly or
Yeah,
for stereotactic?
it's a broad question, but let's stay in topic and let's say for SBRT
Okay, so
specifically.
if you're implementing SGRT, I tell everyone SGRT is a tool. It's just like any other tool we have in radiation oncology. You can use tools correctly. I can bang in a nail with a hammer. I could also attempt to bang in a screw with a hammer. I can use a screwdriver as a hammer. And so you have to be very careful that you set the expectations for the tools that you're implementing. So when you do SGRT, SGRT is fantastic at setting up patients. Like I said, we treat 100% of our patients with it as the only setup tool provided in our clinics. So we trust the system very well, but we trust the system because we've implemented a QA process. We've implemented a daily QA that builds confidence in the system that the system is operating correctly, but that will also detect if something went horribly awry. We just had a camera that a EVS worker accidentally bumped with a ladder, and our morning QA caught it. I mean, it was not even beyond failing. It was at 5/10 of a millimeter, so we weren't worried about the accuracy of the system. But that system was dead on the day before and off by 5/10 of a millimeter the next day, and we knew that something happened. And when we asked, yeah, we bumped it with the ladder. We're really sorry. But we have a tight enough QA process that when you're implementing it, you have to build confidence in the system. And so if you don't have confidence in the system, the worst thing you can do is come on a site visit to a place like mine and say, I'm going to do everything Mike Tallhamer is doing, because you haven't implemented all of the safety checks and all of the confidence building techniques that you need to make sure that the system's working correctly. So I tell everyone, when you implement it in baby steps. You try to pick easy wins for the staff. You obviously, if you're in a clinic that you're running 60 patients a day on a single LINAC, the last thing you want to do is introduce a technology that puts them behind schedule by an hour in the first 3 patients of the day. That's not going to be a win for anybody. And so I tell everyone, when you're implementing it for Stereotactic, the QA process and the understanding of how the system works and what its limitations are is very important. It's going to be impacted by your CT sim workflow for stereotactic, especially your immobilization strategies, your compression strategies. If you're talking about SBRT lung and liver, if you're using giant bridges with paddles and range finders and laser guides and all this other stuff, that's all going to obstruct your patient. So if you're tracking your patient and you're trying to set them up and you have 60 apparatuses on your patient, you're now blocking what you want to track. And so I tell everyone, you kind of have to have a really honest assessment of where does SGRT going to fit into my workflow? What parts of my workflow that I love, that I take home every day and I care for, and it's my precious pet, am I willing to get rid of to have SGRT be more successful? And what parts am I not willing to get rid of? And this just know SGRT is not going to be the tool for that job. And so making those first assessments as you're implementing a program is very important because it keeps you from forcing square pegs into round holes all day long.
Yeah, and as someone that did a Mike Tallhamer site visit many years ago, I know I had the same feeling of being in there. Oh, this is really cool. I can do this, and then going back to the clinic, and then the weight of everything kind of sinks in, and say, yeah, maybe it's gonna be a work in progress. And
Yeah,
so
yeah.
yeah,
There's no shame in baby steps. I mean, we didn't. People come here, and the unfortunate thing about site visits and people coming to see what you're doing is they don't see the 10 years before they showed up. History started the day they walked in the door. And so
yep.
it's history started a long time ago for me. I have earned all my gray hairs, and so I tell everyone you got to earn yours as well.
So I think it's going to be a short answer. Really interesting talk. Thank you. Can you clarify whether collision prediction software is part of the Vision RT software, or is it an independent software system? If so, is it vendor neutral?
So the collision prediction system that we have is called MapRT. It's a commercial product sold by Vision RT. They have an API that goes along with it, and so the non-commercial API softwares that you saw in the talk are all things that I've written for our institution. So it piggybacks on top of the MapRT. So right now, the only collision system I'm aware of is the MapRT product from Vision RT. The nice thing that I like about the implementation of MapRT is it provides the API for users who want to do special things or implement additional QA measures. And so that's been a big focus of ours is as we're implementing new technologies, we don't want to do that in kind of a pie in the sky, like it's just going to work and it's going to be amazing because all the other SGRT stuff seems to work. We always are very cautious when we're implementing something new that we're not implementing something that is not understood or two is going to introduce, like I said, a hole into my Swiss cheese model that passes directly through to the patient. And so the API, the tools you saw that I wrote are things I wrote and they're on GitHub. You can get them but they do rely on the MapRT commercial product provided by Vision RT.
And to clarify, and you showed it in your slides, the MapRT component has hardware component too. So it's two SGRT cameras that are going inside the CT sim,
Correct.
capturing that surface of the patient to be utilized by MapRT and MapRT software in the API. So it's kind of like a all-in-all package that you need to purchase currently solely from Vision RT.
Correct.
Do you have a reference for your compression mask system? So what do you use?
We're using the Orfit AIO solution. So that's the AIO stands for all in one. You can go on their website. It allows you to mask a patient from the top of their head to about mid thigh. I don't recommend doing that. That's probably not a big patient satisfier. But it allows you, it has like 60 some different types of mask configurations. You can have thoracic mask, abdominal mask, just pelvic masks, head and neck masks, chin straps. It's very versatile and very flexible and marries extremely well with SGRT systems. So not just Vision RT system, but any SGRT system because it allows you to maximize the amount of area of the patient you can see, and you're not adding bridges and paddles and cellophane and backlock bags and all the crazy things we use for SBRT are not required. We do everything. 100% of our patients are on the AIO system. It truly is all in one. And so you can look that system up, and they do have some videos where I've done workshops of how to create these compression masks and make them very low profile and very strong and sturdy. And I think they're on their website. You can reach out to them and they can provide you with it. Every rep can provide you with those webinars and those things because we've done those as well.
Just one new one just popped up. What gating window do you tend to use when treating SBRT patients in deep inspiration breath hold?
The deep inspiration breath hold, we typically try to shoot for a 3 millimeter window for deep inspiration breath hold. We don't do phase-based gating. So when I interpret that question of what gating window are you using, or you're thinking like 30 to 70 phase or something like that, we do have the respiratory module for Align RT, which is a respiratory solution if you want to do phase-based gating. We have used it twice, so I cannot even pretend to be an expert on using it clinically. I've done a lot of testing and a lot of phantom testing and phantom work. It's a great product, but it is a clinical decision by our physicians that they prefer breath hold or amplitude based gating. And so if you want to do amplitude based gating, again, our window is 3 millimeters, so the surface has to be within 3 millimeters of the planned surface before we'll use it. But I can't give you a phase window, because I would give you literally the last 2 phase windows I've used in the last 15 years of my career. So
Is it plus minus 3 millimeters or plus minus 1.5?
it's plus minus 3. So we
Okay.
allow a 3 millimeter discrepancy from the planned surface. So it could be
Yeah.
3 millimeters above or 3 millimeters below,
Yeah.
and that's included in our PTV margins, basically.
Yeah. We've tried the phase-based module too, and it just makes the treatment so much longer
Yeah,
and
it works really well, but you do
yeah.
have to have a relatively slow clinic, because if you read the papers that are published, your efficiency model goes in the toilet, and so you're
Yep.
talking like a 45-minute treatment to get through something we can get through in 10 minutes.
I don't know if you want to get into the next question, but uh,
You're going to give it to me anyway.
yeah. Thoughts on exact track dynamic?
Exact Track Dynamic, really freaking cool technology. Um, it has a single forward-facing camera, so if you're thinking of it for SGRT, I just tell everyone, just like I said, every tool has a tool, or every tool has a purpose. It is a forward-facing camera. There's a reason why every other vendor has 3 cameras. You need 3 cameras. Every person who's tried 2 cameras, ask CRAD, ask Qmedic, you end up with 3 cameras, and there's a reason. The solution requires 3 cameras to get the coverage of the area that you're treating, for the accuracy we need in radiation oncology. Now, they do use a thermal camera. They're using a thermal camera to add topology, essentially, to that single forward-facing surface, and that helps that surface to be a little bit more stable. And when I say a little bit, a little bit more stable. They do very heavily rely on their X-ray system, but they are a system that marries SGRT with X-ray. So they're fully capable of relying on their X-ray because they give you an X-ray system. Now, what does that do to your efficiency and your throughput? I think it kills you. I mean, I've worked on exact track dynamic systems. I've been on 2 of them clinically, and there's nothing you're treating in under 40 minutes. It seems like these days for SBRT, especially if you're relying on the SGRT piece. It's just kind of an efficiency killer, because you do have to stop the gantry, take an image, evaluate the image, re-zero the surface, and then continue treating. So as many times as you want to do that, you can do that as much as you want, and it's going to be unbelievably accurate because it's a good system. It does what it says it's going to do, but it comes at a cost of time and efficiency. That's just what I tell everyone. But it makes some really cool pictures, and they got the coolest pamphlets and the coolest like planning system stuff that you'll ever see. It's really, really cool. A lot of really nice things in their planning system. So I'm not in any way bad mouthing. In fact, I was a Brain Lab show site for 7 years, so I have nothing but love for everything Brain Lab ever did for me. But it is not what I would say a fully fledged SGRT system. The SGRT system is basically there to make up for the fact that Exact Track Dynamic no longer has the body markers, and so it's using them in much the same way that it used to use the body markers. So you're getting an SGRT system light, kind of.
Yeah. I think we're at time, but we have 2 more questions. I don't know if
Okay,
we can.
make it
Uh,
fast.
Maybe yes or no questions. But did you use SGRD to trigger adaptive replanning?
We can with the synthetic CT stuff that you're seeing. We use SGRT a lot for head and neck to trigger kind of adaptation. It would take far too long to explain all of that process, but yes, you can use SGRT to trigger some of that. If you see setup issues or changes in surface, significant deformation, you can use that as a trigger. You have to figure out what your metrics are going to be, though.
Yep. For long SBRT with large motion tumors, how do you correlate SIM-RT square patch amplitude to LINAC align RT patch amplitude?
You don't.
Yeah.
Easy answer. You do not.
Yep.
You're
Uh,
looking at the plan and the surface from the plan. So the patch from CT Sim, it is a different approach than what you would think from the old RGSC days. So you just don't. That's an easier answer.
I think that's the last one. At our clinic, we currently have SIM-RT and Align-RT. The small tracking patch in SIM-RT versus the larger ROI during treatment has caused some concerns that we cannot verify the same breathing hold between the two systems because SIM-RT is looking at a very small area. How do you approach this difference and know that the breath hold the patient gave you in SIM is the same on the treatment table? So kind of same answer.
Yeah, so the same answer is you wouldn't correlate them between them. The CT that you captured is your golden reference. So the breath hold plan CT that you're on is what the breath they have to reproduce. So regardless of what they did in CT sim, what you captured on CT is your reference image. And so the tolerance is 3 plus or minus 3 millimeters at my institution around that surface. If we want to verify that they're a consistent breather, we will actually do small sub CTs. So we'll do 3 CTs under breath hold to make sure that each time they get to breath hold, that surface is stable. And so we do basically a MIP of those 3 scans, and we typically see less than a millimeter of discrepancy because we use a 0.5 window. So it's really, really tight. So the bigger that window, obviously, the more variability you're going to allow in that scan. But we'll take 3 small scans to make sure that that breath hold across the treatment area is good.
Yeah, I think the misconception here is that the thinking, like the RGSC's thinking, where you're
Yeah,
looking at just a vertical amplitude change, but with SIM-RT, you're basically you're only the SIM-RT's only role in a DABH scan is to make sure that the patient held their breath while being scanned within your institutional tolerances. What the planner gets is just a breath hold surface, and what Align-RT is going to monitor is that breath hold surface. So it's going to monitor it in more than just up and down. It's going to monitor
yeah,
it in 6 degrees of motion, which what makes
yeah.
it
I
more
see a lot
accurate.
of people try to correlate RGSC workflows with Align RT, and they're like,
Yeah,
well, how do you know where you put the patch is correct?
yeah,
It doesn't matter
doesn't
where you put
matter.
the patch. The
Yeah,
surface that you get in planning is the surface you have to reproduce at treatment. End of
yep,
story. And so the entire surface is your little block that our GSC relies on, essentially.
hmm yep. Yeah, no more questions. So I'd like to thank Mike Tallhamer again for a wonderful talk and RSS for hosting it. So
Yes,
thank you.
thank you.
Yes, thank you so much, Drs. Tallhamer and Robinson, for taking your time to support our educational mission. And thank you again to Vision RT for supporting this webinar through an unrestricted grant. Attendees, look in your inbox for a follow-up email with details on how to obtain your CME certificates. We hope you appreciate the webinars and will consider supporting the RSS by becoming a member. Our next webinar, Stereotactic Radiosurgery for Rare Skull-Based Tumors, is scheduled for Thursday, May 7th. Registration and more information is available on our website. This will conclude today's webinar. Thank you again and have a wonderful day.
Thank you.
Thank you.